think I'm gonna start. Hi everybody. So this is Mohammad. On research, I guess if you guys are missing me, that's what I've been. So my talk today is about chronic diarrhea, specifically about small bowel focused chronic diarrhea. So not like IBD and all the colon problems. It's a pretty fun talk, but also can be extensive. So I tried to summarize the important stuff that we need to know about chronic diarrhea. So I'm going to go over definition and some classification of diarrhea, a little bit about the pathophysiology, and the important, clinical evaluation and workup of diarrhea, specifically chronic diarrhea. And then I'll try to talk about very few, if we have time, very few specific small bowel diseases that are pretty important. And then finally, a little bit about the treatment of chronic diarrhea. So first, let's kind of explore what is a normal bowel movement. We always say like normal bowel movement, and in terms of if you want to classify it in terms of frequency. So these are 7 patients that have like diary, bowel movement diary, right? So you have patient 1, 2, 3, all the way to 7, and this is the time throughout the week, and every dot represents a bowel movement. So I kind of summarized it here about everyone. So, for example, patient 1 has 1 bowel movement every 5 days, and so on. So the question is, which of these patients would have diarrhea, and which would you consider to have constipation? Anybody wants to throw an answer? No? Okay. So in general, I mean, patient 7 obviously has diarrhea, right? And patient 1 obviously have constipation. But the other question would you consider patient 6 to have diarrhea who has 3 bowel movements per day? And the answer is no. In general, we say, 1 bowel movement every 3 days, all the way to 3 bowel movements per day is normal. Anything beyond that is diarrhea, and below that is constipation. And so what is the actual definition of diarrhea? Although it's very subjective when you talk to patients, it's very subjective about how they describe their symptoms. Some people say watery, some people say, leaky, some people say more frequency but solid. So it's really different. But there is an actual, definition. So it is defined by the patients, usually by the increasing liquidity of stool and sometimes frequency. But the clinical definition is if you have more than 3 bowel movements per day, or quantitatively, if you have more than 200 grams of stool per day. So either increased frequency or quantity. So normal bowel movement can be up to 300 grams, especially people who take fiber supplements, because you're excreting all these fibers undigested. And you should always be aware of incontinence, because some people can't differentiate. Some patients will have trouble differentiating between diarrhea and just having incontinence, and that would have to be worked up differently. We'll talk more about it later. And so when you when you're looking at diarrhea, there is multiple classifications of the diarrhea. So it can be classified based on the duration of the illness. So it can be acute versus chronic, or the stool characteristics, so watery, fatty, or bloody, and the pathophysiology, osmotic, secretory, or inflammatory. And then you can also look at population at risk, like AIDS-associated diarrhea or traveler's diarrhea, or even the severity. You can say large volume diarrhea, small volume diarrhea. What we're concerned about is really these first 3, is acute versus chronic, and we're focused more about chronic diarrhea here. And in terms of stool characteristic, this will give you an idea about different differential diagnoses and the actual cause of the diarrhea. And finally, the pathophysiology about whether it's osmotic or secretory or something else. And so, to explore kind of the pathophysiology of diarrhea, you need to understand the normal flow of gastrointestinal contents and how it goes. So from food and drink ingested and your salivary secretions, gastric, pancreatic, biliary secretions, all these, about 9 to 10 liters enter the jejunum, into the small intestine. in the small intestine, about 90% of all that normally gets absorbed into the portal circulation. You end up with about a liter that ends up in the colon, of which 90% is again absorbed back into the circulation, and only about 80 to 100 milliliters of stool should be formed normally. If you have a decrease in the overall intestinal absorption of even the slightest, even 1 to 2%, this is enough to cause diarrhea. So if you have this 90% goes down to 88% from the small intestine, then you will have diarrhea. So if you're not absorbing enough, then you'll have diarrhea. What type of diarrhea would this be called? So if you have inadequate absorption right here in the small intestine, if you're absorbing like 80%, do you know what kind of diarrhea would this be called? Don't have options, unfortunately, but would this be
Osmotic.
osmotic versus osmotic? So actually, this would be secretory diarrhea. It's more or less of a misnomer, secretory diarrhea, but in general, if you have decreased absorption, this is secretory diarrhea, while excess stool water that's poorly absorbed because of there is osmotically active substances that pull out water, then or cause the water to stay in the lumen, then that's osmotic diarrhea. So it can be a little confusing, but in general, when we say secretory diarrhea, doesn't mean that you're actually actively secreting, because you already have about 10 liters in the small intestine that enter, and so you're not actively secreting anything. You're just not absorbing enough. And so to differentiate, the big differentiator between these two is to measure what we call the fecalismotic gap, and this is the difference from the normal osmolarity to 90, and the fecal osmolarity, which is estimated by the stool sodium and potassium multiplied by 2. And so normally this is between 50 and 100. If you have a small osmotic gap, it means that you're secreting osmotically active substances found in the stool, or not secreting, but they are found in the stool, and this is the definition of osmotic diarrhea, essentially. Meanwhile, if it's more than 100 or normal, then that's just secretory diarrhea, if you do have diarrhea. Another way to look at it is to look at the stool pH. Higher stool pH tend to be found in osmotic diarrhea, but usually the osmotic gap is enough to differentiate between these two. And so, again, osmotic diarrhea is defined by excess stool water that results from ingestion of poorly absorbed substances. These remain in the lumen, and they retain the water within the lumen by osmotic effects. And so electrolytes absorption is usually unaffected by these substances, these osmotic substances. It's just that the water gets unabsorbed, and so that's what causes diarrhea. And usually these substances are either poorly absorbed carbohydrates or sugar alcohols, or poorly absorbed ions. So the sugars such as lactose, fructose, or always think about these like sorbitol or the sweeteners, the artificial sweeteners. The other day we had a patient in the VA who, when we questioned him more, he was having diarrhea, but he was also chewing like 30 pieces of gum a day, and that's what was causing the diarrhea. And so that's typically just osmotic diarrhea. Meanwhile, ingestion of magnesium or other unabsorbed or poorly absorbed ions can also cause osmotic diarrhea. While osmotic diarrhea has like a small, differential diagnosis, secretory diarrhea is kind of where the money's at. It's where really is difficult sometimes to differentiate. So when the osmotic gap is small, then the electrolytes account for the osmolality. And secretory diarrhea, again, as I mentioned, is somewhat of a misnomer, where most patients with secretory diarrhea they have a small osmotic gap, and they still absorb most of the 9 to 10 liters of fluids, but they just don't absorb most of it. So they don't secrete actively; they just don't absorb most of the fluids. And so there are several mechanisms, at least 6 different mechanisms by which secretory diarrhea can occur. So it can either occur by virtue of infection, or by reduction of the mucosal surface of the small intestine or even the colon, or if there is some sort of absence of the ion transport mechanisms of the enterocytes, or it can be induced by inflammation, dysregulation such as neuropathies such as diabetes, and finally by the effect of circulating secretagogues that can be secondary to neuroendocrine tumors or peptide secreting tumors as a paraneoplastic condition. And so in terms of infections, it's really usually acute diarrhea that presents that the infective secretory diarrhea is usually an acute form of diarrhea rather than a chronic form. And chronic infection can exist, especially in immunocompromised patients. Some people with IgA deficiency can end up having chronic parasitic infections such as Giardia. But it can either be, in general, can either be due to direct bacterial invasion, or the enterocytes can be destroyed, or it is secondary to toxin production, such as cholera. While the other mechanism is the reduction of mucosal surface or the mucosal surface area. So I like this figure. This figure gives you an idea about which part of the intestine absorbs what exactly. And if you look at it, there's a proximal part, middle part, and distal part. Different nutrients and different electrolytes can be absorbed in different places. And the important thing to remember is that this absorptive function is really different from part to part of the bowel. And so some segments cannot really compensate for the missing function of others. So for example, if you lose your ileum, you're going to have trouble absorbing vitamin B12. It's not like the jejunum is going to suddenly start absorbing it. So sometimes that's what happened, and then you end up having secretory diarrhea. So the other thing is that even general absorption, even if other segments can compensate, you must have enough of them to be able to compensate. If you lose all your small bowel, the colon alone is not going to be able to effectively absorb enough, even if it's functioning normally. The other mechanism is the absence of ion transport. So this is usually congenital when you have absence of transporters such as chloride bicarb transporter or sodium proton antiporter. These can be absent genetically or congenitally and can cause a form of chronic diarrhea that may persist into adulthood. But I doubt that this would be important right now in adult life. And inflammation is the other cause. The immune system in the intestine does modulate electrolyte absorption. If you have increased cytokine release and you increase inflammation, local or systemic, it can affect not only the absorption of electrolytes, but also it can affect the enteric nervous system and can cause a form of diarrhea. And this would be secretory diarrhea. All these are secretory diarrheas. Dysregulation is, what I mean by that is the dysregulation of the autonomic nervous system or the enteric nervous system, and this usually occurs at a complication of diabetes or other polyneuropathy or other forms of polyneuropathy. When you have abnormal function of the enteric nervous system, this will affect the dynamics of intestinal fluid absorption and motility. And similar things can occur in patients who are post vagotomy or have like celiac plexus neurolysis, or essentially it's more of a neurologic condition, either caused by neuropathy or us, or like iatrogenically we're inducing a form of neurolysis. And then finally, when you have circulating secretagogues, this is by far the rarest, one of the rarest causes of secretory diarrhea. So when you have tumors of endocrine cells, either in the gut or pancreas, like a VI-poma or like other tumors, they can produce high enough amounts of circulating secretagogues into the system that either increase the secretion or inhibit the absorption into the small intestine. And this can present with diarrhea. So examples would be, neuroendocrine tumors or like carcinoids, these can be metabolically active, can cause paraneoplastic syndromes that end up in diarrhea. And so, now that we kind of, understand the mechanism of by which diarrhea can occur, the important thing is once you see a patient with diarrhea, how do you evaluate them? And really, history and physical exam, and history by far, a thorough history is the most important step in managing these patients. We talked about acute versus chronic, and again, we're concerned about chronic diarrhea here, and really the cutoff is 4 weeks. So the duration of diarrhea, 4 weeks is the cutoff point that we use to differentiate between acute and chronic diarrhea. And so you're going to have to ask patients about the duration of the diarrhea, the frequency of the bowel movements. You have to, kind of discuss, as we talked in the beginning, like, is it really diarrhea? Does it really fall into the definition of diarrhea, or is it just increasing than the usual bowel movements that the patient was having? Sometimes, as we discussed, this does not correlate with stool weight, as some people may have higher stool weight, increased amount, by ingesting more fiber, but they still don't have actual diarrhea. And so when somebody's having diarrhea, you need to assess their hydration status, because if they're having a lot of bowel movements and they're dehydrated, so by history, you're going to ask them about thirst, and you're going to ask them about decreased urine output and some sort of fatigue or weakness. And if you notice weight loss, especially if it's acute, then that's an indicative of severe diarrhea, regardless of how you try to quantify it. This would be more an objective measure. And you always ask about stool characteristic. You want to ask if there is oil droplets, if there is undigested food in there, if there's mucus or blood that can sway you one way or the other for a differential diagnosis. Important question to ask is the relationship of defecation to meals or fasting. What is the significance if diarrhea is present on fasting or not present on fasting? Is there any significance to that? Can it differentiate between two things? Anybody? Here's somebody trying. That's fine. So it usually differentiates between osmotic and secretory diarrhea. So osmotic diarrhea resolves with fasting, as you guessed it. You're not ingesting all these osmotically active substances, and so when you fast, then they're not having the diarrhea. So that may give you a clue even before testing the fecal osmotic gap. The other thing is you want to ask about passage of stool during the day versus passage of stool during the night. Again, what would be the significance of having nocturnal symptoms versus not? I think this one is easier. No one?
Secretory can be nocturnal.
So, in general, when there is nocturnal symptoms, then there is an organic cause that's causing it. You're right. If it's osmotic diarrhea, though, like if it's caused by ingestion of substances, it can still happen nocturnally. But more so, if there is nocturnal symptoms, then you think there is really a organic cause. While if there's no nocturnal symptoms, then you might be more reassured that this is mostly a functional a problem like IBS or something else. And always, be aware, as I mentioned earlier, about urgency or incontinence. These are not diarrhea. So these reflect really a rectal problem rather than severe diarrhea. And you really should kind of try to talk the patient about what they're really having and try to find out if it's really incontinence rather than diarrhea. You're going to always ask about associated symptoms. These include abdominal pain, flatulence, gas, bloating, cramps, fevers, or weight loss that can, give you an indication about what's going on. And you always have to explore the patient's diet in details, what they're having for breakfast, lunch. So what I usually ask is walk me through a day. So what do you have yesterday? And then go through the entire day with the patient, including the snacks that they eat. And more so than not, I discover like weird things or exotic things that they usually eat, and that may cause diarrhea. And always check for Fodmaps, right? We always say low Fodmap diet. We always talk about Fodmaps. So not only what are Fodmaps, well, what kind of diarrhea do Fodmaps cause? Anyone? So is it secretory or osmotic? So it is osmotic diarrhea, right? Because you're ingesting these fermentable foods. So FODMAPs stand for fermentable, oligo, di, monosaccharides, and polyols. So these foods usually, when they stay in the intestine, they can cause osmotic pull and keep the water into the intestine and cause diarrhea, osmotic diarrhea. And this is a nice chart of like kind of common vegetables and foods that we use. And the bars gives you how FODMAPy the food is. And so you can see like mushrooms, cauliflower, beans, usually they're very saturated in these FODMAPs, while if you go all the way down, seaweed, cucumber, the eggplant, they don't have it. And so the way these FODMAPs actually cause the diarrhea, they cause they have multiple ways of doing it, but typically when you have the FODMAPs into the lumen of the intestine, they osmotically they're osmotically active, and so they cause water retention, but they also are rapidly fermented in the colon, and that's why they cause gaseous distension of the colon. People will have, the patients will have gas or increased distension, gaseous distension. And then finally, these short chain fatty acids might induce motility of the small bowel and colon, and that might worsen the diarrhea. And the other thing that they do is they actually can alter the microbiome or the microbiota, and then that can cause a diarrhea. So they cause osmotic overload, they cause bacterial fermentation, and sometimes dysbiosis, and you end up with gas and bioactive metabolites and lipopolysaccharides that can cause diarrhea. And that's the way they cause. But in general, it's an osmotic type of diarrhea. And so the other thing you want to explore in the history is to ask about specific factors, medical, epidemiologic, previous surgeries, certain risk factors that puts the patient in different categories. So, for example, AIDS patient, HIV infected patients can have specific opportunistic infections or drug side effects. Patients in long-term care facilities that can have like C. diff or can have other, can have problems with like tube feeds that can cause the diarrhea. Travelers, if you have epidemics or diabetics, will have different kind of differential diagnosis of different risk for different types of diarrhea. And then finally, you also want to ask about social history. You want to ask about the place of residence. So if they live in a rural place or they live in a city, this may affect the source of drinking water that they have. You want to explore the patient's occupation, sexual preferences and activity, and exposure to farm or pet animals. And finally, the use of illicit drugs or alcohol. And always consider the potential secondary gains from the illness. So if there's a history of attempted weight loss or fixation on body image, then this may raise the possibility of like laxative abuse in some patients. And so after you explored all that kind of extensive history, you got an idea about what's going on. Next is to do the physical exam. Really, the physical signs are more helpful to determine the severity of the diarrhea rather than really the cause of the diarrhea. So you always want to assess the volume status in somebody who has diarrhea. So check for orthostatic changes in blood pressure and pulse, and then you can go on the rest of your exam. So when you do your abdominal exam, this will include auscultation for bowel sounds. And when you auscultate for bowel sounds, you have to describe the frequency of the bowel sounds. And what is the normal frequency of bowel sounds when you auscultate? Trying to get anybody to throw answers, but I guess you guys can chat. I guess you can type in the chat as well. Anybody knows what's the normal frequency of bowel sounds when you auscultate? Right. So somebody says 30 hertz. Yeah. So it's anywhere between 5 and 34 per minute. Not really hertz, not per second. That would be really fast. And then after that you're going to describe the intensity, location, and pitch, and then finally the pattern of the bowel sounds. This might give you an idea about what's going on. If there's hyperactivity or hyperactive bowel sounds, that might indicate there is that might kind of give you an idea that there is increasing motility that's causing the diarrhea sometimes. And you want to assess the presence absence of abdominal distension, and check for tenderness. And sometimes on rare occasions, your physical exam might actually elicit more direct evidence about the cause of the diarrhea. And these can be characteristic rashes, right? So what is this first one? What is this first rash? Anybody can guess? And what it indicates? Dermatitis.
Dermatitis herpetiformis.
Yep. So this is dermatitis herpetiformis with celiac disease, right? How about this one? So this is a comparison between two hands. Gaucher's papules. No, so this is hyperpigmentation, which sometimes you see in Addison's disease, which can present with diarrhea. And then this one right here. No one is. So this is like facial flushing, right? So this one you could see in like carcinoid syndrome. That can cause diarrhea, and then ends up with facial flushing is one of the distinctive features of it. So again, these are rare, but always try to look for rashes, or at least ask the patient for rashes. Some people do manage to tell you. So while you're palpating the abdomen, you're going to check for organomegaly. Hepatosplenomegaly can be seen in some infiltrative diseases such as amyloidosis that can end up in amyloid enteropathy and can cause diarrhea. And then don't forget to examine the thyroid, because hyperthyroidism is also another differential, and you have to check for nodules, goiter, and you examine the thyroid from behind the patient, and you always check for that, and always auscultate the heart, because tricuspid regurg can be indicative of carcinoid syndrome. And then most importantly, don't ever forget a DRE in patients with diarrhea. So always you have to do a digital rectal exam. And what you're really looking for, you're carefully examining the external anal sphincter, see any defects, and you're assessing the tone of the sphincter during the exam. So make sure the diarrhea is not really incontinence that the patient might be having, and you're pursuing different things. And check for any masses while you're palpating, and check for any stool impaction, because that can be the cause of overflow diarrhea, especially in bed-bound patients who come from nursing homes. And so after you're done, you did your physical exam, you did your history of physical exam. So there's always further evaluation. So we've done the history, we've done the physical, we've done the fecal, assumingly fecal osmotic gap, and now we know it's secretory or osmotic. You might want to do more, lab work if it's still elusive, you still don't know what's the cause. So you can check a CBC, a CMP, and then check if inflammatory markers. And it's always good to just screen for celiac disease. And don't forget to send a total IgA. You can send a fecal lactoferrin or leukocytes to check for inflammation. Send a stool culture, the C. diff screen, and O&P as well, O&P, stool O&P, ovum parasites. And if available, I know in county we have this, we send the PCR, the stool PCR. That can give you a specific cause of the diarrhea, and sometimes even obscure causes, viral causes sometimes. So if the history and physical exam lab test reveals something, so if you know already, you kind of reached out the problem, then you can, start empiric therapy. And sometimes you don't need to go further. You don't need to scope these patients. You don't need to do imaging. If only your history and physical exam and some of the lab results give you an answer. However, when there's no diagnosis, then you should always consider these 4 possibilities before you pursue further. The first possibility is fecal incontinence, that is masquerading as chronic diarrhea. You should always consider that as the cause, explore it a little bit more, either by virtue of physical exam or testing. The second thing is iatrogenic diarrhea due to drugs or surgeries or history of radiation therapy. So you should try to explore that more. And number 3 would be a chronic infection that you didn't pick up, and that's where the PCR, the stool PCR, might be helpful. And then finally, IBS with diarrhea. That also can be the cause. So we talked about like kind of acute versus chronic, and now I want to talk about chronic watery diarrhea versus chronic fatty diarrhea. So when you have chronic watery diarrhea, it's a secretory. It's when you do have a secretory diarrhea, it can present as watery diarrhea, and this can have a very broad differential diagnosis, as you will see in next few slides. But really, the common thread among all these conditions is that salt and water absorption is impaired, and so you're not having enough absorption. And that's why it's called secretory diarrhea that I mentioned earlier. And you should always exclude the infections. We talked about the 6 different types by which secretory diarrhea can be caused, and so you should exclude infections if not previously evaluated. You can send the PCR for these patients if they truly have chronic watery diarrhea and you don't have any other cause of it. Then PCR can be really helpful. To look for peptide screening tumors, it's really very rare, and screening all patients can produce false positives and true positives. So don't routinely send any sendouts for like peptides, specific peptides for neuroendocrine tumors. Only when you have either extraintestinal or tumor-related symptoms, like flushing for carcinoid, then maybe you want to send out these tests, but generally you don't have to. Okay. One consideration is BAM. You guys ever heard about this? Which is bile acid malabsorption, right? BAM. I think we see this more often, or we think about this when we're evaluating patients with IBS, but this is an important differential for chronic diarrhea, and this can cause what we call bile acid diarrhea, BAD. And it's usually caused by ileal disease or resection that allows excessive amounts of conjugated bile acid to enter the colon. And if the concentration of these bile acids are high in the colon, exceeding 3 to 5 millimole per liter, then electrolyte absorption will be inhibited and secretory diarrhea may result. There's 3 distinct types, and this is kind of beyond this talk, the diagnosis is a little bit controversial. There's different types to do the diagnosis. We can do the diagnosis. So this is the kind of the pathophysiology of what really happens. So on the left side is the normal enterohepatic biliary circulation, right? So this is then an ileal enterocyte. So when you have bile acid in the ileal enterocyte, there will be increased bile acid absorption. When that happens, the enterocyte will signal back to the hepatocyte to decrease bile acid synthesis. For some reason, when you do have decreased bile acid absorption because of there's impaired absorption of bile acid, then this inhibitory signal will be affected, and there will be normal or increased bile acid synthesis by the hepatocyte, and then that will end up entering the colon. And when that enters the colon, that will cause colonic motility, and it will cause fluid secretion and retention and inhibition of absorption, and you will cause secretory diarrhea. So to diagnose it, again, it's a little bit tricky, but there is multiple tests to diagnose bile acid malabsorption. The one that we don't have here in the US is called the selenium homotaurocholic acid 7-day retention test that is validated in European countries. We don't have that, so we don't use it. You can do a fecal bile acid test that quantifies 48-hour stool collection, which you can expect is really hard to do. And then finally, there's the 7-alpha-hydroxy-4 colistin 3-one, which is 7-alpha-C4, or just C4 for brief. And I know I've sent this test a few times when I worked in the VA, and this is a blood test. It's the downstream product of hepatic enzymes, and the fasting C4 levels, they increase when bile acid synthesis increases. So it correlates with bile acid synthesis. So it's really elevated in bile acid malabsorption. However, sometimes you can have false positives, false negatives in people who have either liver disease or taking statins, but this seems to be a good enough test if you're really suspecting this diagnosis. And usually treated by bile acid resins, which we will talk about later. And so this slide just shows you kind of the extensive differential diagnosis of secretory diarrhea. So you have really a wide differential diagnosis. It varies from celiac disease to vasculitis to endocrine diarrhea to even to what we call idiopathic secretory diarrhea, which is when you really don't have a cause. Just people have secretory diarrhea. So how about chronic fatty diarrhea? So we know what is this? So this is stool sample. So this is steatorrhea, right? So fatty diarrhea is characterized by having steatorrhea, and that implies disruption of either fat solubilization, digestion, or absorption in the small intestine. Fecal fat content can be actually measured. You can measure it quantitatively, you can measure it semi-quantitatively, or just qualitatively. And the major causes include either mucosal disease, such as celiac disease, can cause steatorrhea, or pancreatic exocrine insufficiency, such as caused by chronic pancreatitis, or structural abnormalities, or lack of bile, such as in advanced cases of primary biliary cholangitis. You can end up with fatty diarrhea. So your initial steps would be to prove it, to measure the fecal fat content, and the concentration of more than 9.5 gram per 100 gram of stool strongly suggests the presence of this. The cause is usually suspected from either the clinical presentation and the history that you're taking. So really you should try to take a really good history to know what's causing it. And the tests can include, the serologies for celiac disease, or you may end up pursuing an upper endoscopies with biopsies, like a push, balloon, or even capsule endoscopy, like enteroscopy, or even enterography to check for the small intestinal disease with CT or MR. And then finally, it does include testing for exocrine pancreatic insufficiency, especially if there is high suspicion for this. The way you test for exocrine pancreatic insufficiency in steatorrhea is you can either do a stool chymotrypsin. It's usually used in pediatric population, limited sensitivity and specificity in chronic diarrhea, so we don't tend to do that. This can be suggested, so exocrine insufficiency can be suggested by imaging. So if you do CT, MRI, or EUS, if there is abnormal or structural abnormality of the pancreatic ducts that provide extra evidence that this is what's going on. And then, more objective tests that we don't really use anymore, that is a CCK or secretin stimulation, and then endoscopically collecting pancreatic secretion. That, kind of sounds like a gold standard test, but it's really invasive and there is no need. And then finally, there is a fecal elastase test that we tend to use a lot. It can be used. However, you should always know that false positives can occur and do occur in watery diarrhea because the elastase gets diluted. So just be aware when you're using any of these tests that there is sometimes false positives. So fecal elastase, when it's low, it's positive, right? You don't have enough elastase, which means pancreas is not secreting it. That means pancreatic insufficiency. But this low level can be present in watery diarrhea. However, what is the really most available? What is the most practical method that we use clinically? So it's really empiric treatment. So therapeutic trial, you give them pancreatic enzyme supplementation, and if they're symptomatic, you either can check symptomatic relief or measure fecal fat excretion, and that can give you an idea that this is really what's going on. If they improve, then that's your diagnosis. Again, the differential diagnosis for fatty acid chronic diarrhea can be either malabsorption syndromes, such as mucosal diseases, short bowel syndrome is important, mesenteric ischemia, or maldigestion, such as pancreatic exocrine insufficiency. I know we're all thinking, okay, is there an algorithm for all this? Can you just show us an algorithm? And there's somewhat of an algorithm to all this, right? So again, you have somebody with chronic diarrhea. You do your history physical exam, you get your lab test, you differentiate between osmotic and secretory, and then you consider the 4 possibilities that we talked about. Fecal incontinence, you consider that, and then you can evaluate it by DRE or anorectal manometry. Consider iatrogenic diarrhea. Explore drugs, surgery, radiation therapy. Consider chronic infections such as protozoal or other bacterial infections. And finally, consider IBSD, or even like bile acid malabsorption or something. And then, the IBSD, you can always consider like SIBO or small intestinal bacterial overgrowth. I'll talk a little bit about later. And then if everything is kind of negative, then it's complicated or severe persistent refractory diarrhea. And this is the one that really can, it's a head scratcher, and you need to think about. So if you do have this complicated severe refractory diarrhea, then you might end up doing either more imaging or doing colonoscopies or endoscopies, and doing more laboratory tests, such as sending the PCR, the multiplex PCR. And then, if you do the imaging and you don't have any structural abnormalities, sometimes you can just diagnose what's going on by biopsies and structure. If no structural abnormalities exist, then you might end up exploring more and more about what's going on to kind of key in on your differential. But it's not really a simple algorithm, and I wouldn't just follow this just like step by step. I think it's more of like your history and physical and clinical judgment about what to do next. And so, when you do have osmotic diarrhea versus secretory versus fatty diarrhea, again, different causes and then different things that you want to do for each of these. So if you have osmotic diarrhea, then you want to review like the stool pH. You want to maybe look at stool magnesium. Sometimes if there's a clinical suspicion of like having high magnesium or having like laxative abuse, sometimes this would be the cause. In secretory diarrhea, then you might end up getting a small bowel biopsies with upper endoscopies or enteroscopies, or you might end up the C4 test that we talked about, or even just try a bile acid binder and see if that helps. And same for like fatty diarrhea, is sometimes you just want to empirically treat those excretory insufficiency and see what happens. That would be really diagnostic as well.
And so, Mohammad, hi, it's Dr. Frank. I just make a comment. I just want to mention to the VA, at least at the VA, and also elsewhere, you can send the C4 test to LabCorp. You just have to make it. It's a miscellaneous lab test, and we've actually sent that. So it is available, and maybe we should be looking at it more often in these kind of cases. Anyway, just wanted to make that comment.
Thanks, Dr. Frank. So I'm just gonna briefly talk about a few kind of specific small bowel diseases. So there's really plenty of small bowel diseases that can cause diarrhea. These can include celiac disease, other types of sprue, Whipple's disease. The ones I will talk about are these three, really: medication-induced enteropathy, autoimmune enteropathy, and small intestinal bacterial overgrowth. Although there are others, I don't think I'll have enough time to cover any of the others. I think each of these sometimes may warrant a whole lecture by itself. But I'll start by the first one, this medication-induced enteropathy. So when you hear about this, so this has been increasingly recognized, and when you hear about medication-induced, enteropathy, what is the first thing that comes to mind? What is the medication that comes to mind? Right. Somebody says olmesartan. Yeah. So it's NSAIDs and olmesartan. So olmesartan is the one that is this is the board answer. This is the one that at least you're going to see on your DDSEP. You're going to see probably on your boards. So NSAIDs and ARBs, mainly olmesartan. So NSAIDs can induce small bowel or small intestinal ulcers. These ulcers may end up in even strictures. This is a picture of a small intestinal stricture caused by NSAIDs that you can see here. And olmesartan, rather than producing ulcers, it rather produces kind of enteropathy that can be characterized by villous atrophy and inflammation. And really, you will diagnose this by history and history really, and your treatment is to avoid the medication. So avoid NSAIDs and probably switch to a different class or a different ARB rather than olmesartan. Although I want to say different other angiotensin receptor blockers have been elicited in this, and even valsartan can cause this entity, but olmesartan seems to be the one that causes it the most. The next one is autoimmune enteropathy. So autoimmune enteropathy is an autoimmune condition. It's characterized by severe diarrhea, characterized by weight loss, secondary to a malabsorption and villus atrophy. Patients with autoimmune enteropathy have specific antibodies, but they also have non-specific antibodies. So the specific antibodies include anti-enterocyte antibody and anti-goblet cell antibodies, but they also may have ANA, they may have other sorts of antibodies. So this is typically a pediatric condition, but it can actually present in adults, and there's a whole entity called adult onset autoimmune enteropathy. And so the diagnosis of the adult enteropathy can be based on kind of proposed criteria. These also require endoscopic biopsies, and so these proposed criteria were put forth, I think, in 2007 by this paper, and it includes adult onset chronic diarrhea that for some reason they classified it as more than 6 weeks rather than 4 weeks, having malabsorption, and specific small bowel histology, such as deep crypt lymphocytosis and minimal interepithelial lymphocytosis, such that interepithelial lymphocytes, the ones we see in celiac. And then you want to exclude other causes of villus flattening and having the antibodies. So having 1, 2, 3, and 4, these 4 are required for a definite diagnosis. While if you have some of them, then it's not really a definite diagnosis. So this condition can be a part of a multi-system involvement. However, this really described in kind of scattered case reports that I saw here and there. Other associated autoimmune conditions may be present, and these include other GI autoimmune conditions. And these include atrophic gastritis, autoimmune hepatitis, PSC, and Zika syndrome. Although all these are really, again, they're really case series rather than population studies or big studies that showed this. So just be aware of this condition. When you see somebody with other autoimmune conditions, sometimes maybe consider this if you have unexplained small bowel diarrhea. The treatment is usually supportive. You adequately hydrate them and you give them nutritional support, but if they have severe cases and they're having weight loss or having just persistent cases, then you can use steroids. And this is the first line therapy. If they don't respond to steroids, then you can use other immunosuppressive agents like cyclosporin, Tacro, MMA, mycophenolate, or azathioprine. These may be successful in the past. And finally, just briefly about small intestinal bacterial overgrowth. I think maybe we'll see this more often than the previous two conditions. And this usually occurs when there is abnormal anatomy, although it can occur without abnormal anatomy. It can occur only with altered motility. So if you have post-surgical changes, if you have some strictures, then that you may be susceptible to small intestinal bacterial overgrowth, or if you have altered motility. The etiologies can include, diabetes that affect the motility, celiac disease that again can affect huge parts of the mucosal surfaces that may influence the microbiome. IBS is considered more of a kind of not really an etiology. It can be an etiology, but it also can be a manifestation more so. And other conditions that can affect the motility, such as scleroderma. If you have surgical, afferent loop can grow. This is kind of known to grow, more bacteria and can cause the condition. And if you have, strictures or adhesions causing intestinal obstruction, that may promote overgrowth of bacteria. So clinically, this presents with diarrhea, gas, bloating, can present with constipation sometimes, but more so diarrhea and gas and bloating and anemia. So you get vitamin deficiencies, right? Particularly vitamin B12 deficiency. Why does this cause vitamin B12 deficiency? So the reason why is because the overgrown bacteria, the metabolism of these bacteria, they take the vitamin in, the vitamin B12 kind of it internalizes into the bacteria, and the bacteria uses it for its own metabolically active substances, and what it spits out is ineffective metabolites of vitamin B12. So really, it's the bacteria itself using the vitamin B12. That's why you get vitamin B12 deficiency specifically. The gold standard of diagnosing small intestinal bacterial overgrowth is doing a jejunal aspirates, and you do this by means of enteroscopy. And if you have a jejunal culture that grows more than 103 to 105 thousand colony forming units per milliliter, then that's the definition. That's essentially the diagnosis. However, this is invasive. You don't want to do this for everybody with IBS, and you suspect this. And so there's alternative methods. The alternative method is more practical, and this is the hydrogen methane breath test. The problem with this test is not standardized and really has variable sensitivity. And so some people just say, just treat, right? And treatment response can be the best diagnostic tool, as like with other conditions kind of in this chronic diarrhea part. And so when I was kind of looking at this, there's actually a commercial, not really commercial, you can buy it. You can buy a test. You can buy the breath test at home. So it's $200, and the reason I include this is because they have a nice graph about what constitutes a positive breath test. So you're testing either hydrogen or methane, and so there is kind of at least two distinct types of bacterial overgrowth. It can be either hydrogenic bacteria or methanogenic bacteria, and so if you have a rise of more than 20 part per million from baseline within 90 minutes, then that's a diagnostic of hydrogen positive or of like SIBO. While if you have increase of 10 part per million, then that's methane. Sometimes you also get mixed. The other thing they don't mention here is that sometimes you have other gases that can be caused by bacterial overgrowth and can cause symptoms, but they're not hydrogen or methane, are not detected by this test, and this can include like hydrogen sulfide or other gases. So the treatment is really correcting any anatomy, any problem with the anatomy. If you have like a stricture, you may dilate and that may resolve it. If you have a surgery, if it's possible to reverse the surgery, then that may correct the small bacterial overgrowth. The goal of the therapy, you have to remember, is to reduce, but not to completely eradicate the burden of bacteria. You don't want to kill all the bacteria in the body. You just want to reduce the burden of it. And so what we typically do is 7 to 10 days of a non-absorbable antibiotic, which is rifaximin. This is the first line. Some people have used other antibiotics, metronidazole, seen cephalosporins being used, but really this seems to be the best thing because it's non-absorbable. Some people talk about probiotics. There's really conflicting evidence about probiotics. Some studies say it works. Some studies say it has no effect whatsoever. So for now, we're not really suggesting any probiotic use. And so finally, if the treatment of diarrhea, in general, there's really treatment of the cause of the diarrhea, but really when you look on the diarrhea itself, you really just want to ensure that the patient is adequately hydrated. So supportive therapy of diarrhea more so. So you want to give them enough hydration and fluids, and when you want to suggest fluids, we suggest sometimes Gatorades as fluid replenisher, but really it does not have enough sodium to replenish the stool losses. So you wouldn't want to suggest this. What you want to suggest more so is some other electrolyte kind of rehydration solutions that are available, such as Rehydrolate or Cerulite or Pidilite. These can replenish the electrolyte losses. So empiric therapy is used in patients with chronic diarrhea in these three situations, even if you don't have a diagnosis. So if you want to temporize the diarrhea or initially treat it before you diagnose, or use the treatment as a diagnostic tool, or you want to use it after diagnostic testing have failed to confirm a diagnosis, or when the diagnosis have been made but there's no specific treatment available, then you might want to just deal with it empirically. And therapeutic trials of either bile acid resins for like bile acid diarrhea or pancreatic enzyme replacement for pancreatic insufficiency have been used previously. And then finally, symptomatically, you can just use opiates to kind of slow down So these are the non-specific antidiarrheal agents. The opiates ones, the one we commonly use is loperamide, but others, you can use other ones. And I haven't really seen this resicadotril being used, but I've heard about it being used as a low side effect opiate. But I've seen others use even octreotide, and as we talked about, cholestyramine as a bile acid resin, and even fiber supplements, especially if you're suspecting IBS-D. And so just like a few take-home points. So normal bowel movements, again, once per 3 days to 3 times per day. That's all considered normal. Chronic diarrhea means diarrhea more than 4 weeks duration. And then, Fecalismotic Gap is really a good tool. You can look at it. If you have osmotic diarrhea, it's really a simple differential. You have secretory diarrhea, it's a very wide differential. And then, history. It's really taking a thorough history is the most important step in figuring this out. And never forget doing a DRE during the physical exam, especially if you want to look for like incontinence. You really want to know that. And then escalate appropriately based on your clinical judgment. There's no algorithm that will tell you what to do next. It's really clinical judgment. And so you want to do some test imaging or even scopes and biopsies. And then finally, try to look for any extraintestinal manifestations. This can be the only clue to some conditions, such as AIE or amyloidosis or celiac disease. And then finally, sometimes the empiric therapy can be really a diagnostic tool. Thank you, everybody, for listening. Thank you, Dr. Furstenberg, for supervising the talk. And if you guys have any questions.
Mohammad.
Yes.
Can you hear me?
Yes.
I'm very concerned about the extensive use of this new PCR test that tests for every pathogen that's in the stool. Because you've seen patients come into the emergency room with 1 or 2 days of diarrhea, which is probably a self-limiting infection that's going to resolve on its own in 5 days. And they get this stool PCR, and they find things like enteropathogenic E. coli, which is a pathogen, but it's probably not the cause of the patient's diarrhea and doesn't require treatment. Then they take the bug, enteropathogenic E. coli, they look it up in a Washington manual, and they find what antibiotic treats that, and they find, oh yes, azithromycin can treat that. So they label the patient as having enteropathogenic E. coli, and they give him azithromycin. I think we have to be very careful about using those methods, because most of these cases are going to resolve on their own. And this test is more sensitive than the diarrheas that we're going to get. It'll give you all kinds of pathogens that are not related to the patient's cause of diarrhea, which is probably just a viral gastroenteritis that's going to go away.
Yeah, I think a lot of the places that I looked in, they don't, they call for the PCR test to be used only when, you're kind of in doubt or you don't know the diagnosis, you've kind of, exhausted other tests and you still are looking for infection. So when you're suspecting like a chronic infection, then the PCR test might be helpful if somebody continues to have the symptom, continues to have diarrhea, rather than just right off the bat to send it.
Yeah, but it's being used that way and it's very annoying. Does anybody else have any questions?
I just have a comment, Mohammad and Dr. Furstenberg. That was actually one of the better talks, core curriculum talks on diarrhea. I like how you stressed all the basic concepts and asked questions. Very, very well done. As always, I would ask you to share some good review articles that you used in your preparation. I think of particular importance would be, you mentioned lots of tests or at least few we don't routinely use. So if there is any recent guideline from one of the societies, particularly on the, workup, or any good review articles, I think that might be worth sharing. Thank you.
Yeah, so when I looked, there's the guidelines, I want to say are lacking. So I found the guideline from like 2018, but it's more concentrated on IBS-D. I will share this. This is the AGA guidelines from 2018. But there's also a very nice review article from Mayo Clinic that goes through the evaluation of chronic diarrhea, and it goes through it by looking at 5 different cases, and they have like what they call the 5-step approach. I will share this. I didn't put it in my talk, but I will share it because I thought it was like very helpful in looking at diarrhea.
Thank you, and good job. Thanks.
Thank you. All right. I guess if no other questions, we'll conclude. Have a good day, everybody.